Welcome to the 2021 Virtual Human Growth Foundation Family Day. I'm joining you from the beach today, as you can tell. So usually we have these events in Florida. So I'm trying to channel those Florida vibes today, or Hawaii vibes. Joining us today, I have several people. We're going to go through and have various talks, and we'll have a chance at the end for people to ask questions. So let me introduce our panelists today. Catherine Messinger is a longtime member of the Human Growth Foundation Board of Directors. She's a nurse and practices in Florida. Joining us is Thomas Messinger. He is a licensed a clinical social worker who's going to talk to us today about bullying. And then I have Caden and his mom, Valerie, who are here. They're going to give us a very unique input and tell us a little bit about just how life is for them. And then not on our call yet is Dr. Juan Otero, who's also a member of our board. Dr. Otero is a pediatric endocrinologist with Arkansas Children's, and no doubt he's in the midst of taking care of endocrine issues. So a couple of housekeeping things before I kick off our meeting here. So first of all, I want to thank our sponsors today. So AbbVie, Arbor Pharmaceuticals, Ascendus, Novo Nordisk, and Pfizer. We have a virtual exhibit hall, so feel free in our breaks to stop by and check out the booths in the virtual exhibit hall. The last thing I want to say is, again, I want to thank you all for taking time out of your schedule to be part of our virtual meeting today. And I hope that next year we will be able to have an in-person meeting with you all. So again, thank you all again. Look forward to hearing from you all and hearing your questions. There are two ways that you can submit questions. There's a Q&A. You can also, if you happen to be on a mobile device, sometimes the Q&A doesn't work. You can use the chat function as well. I'll do my best to go through all the questions. And again, we'll do the majority of our questions at the end. So with that, I'm going to go ahead and transition over and kick off this program and talk to you all about growth. And then I'll be your MC and we'll moderate the rest, and we'll have our other speakers join us. So give me a second here and I will get my screen up here. There we go. Okay. So growth, when to worry. So again, the Human Growth Foundation, just to begin or to set a little bit of background here. So I'm a pediatric endocrinologist, and so growth is one of the things that is near and dear to the heart of pediatric endocrinologists, and is a large portion of what we deal with. So looking at differences in growth and trying to basically determine, are these okay or not okay, is probably one of the biggest things. And again, that it's certainly I think a source of concern and worry for a lot of families as well. And so I'm very pleased to be a partner with them and help to evaluate them and offer them insight in terms of differences in their child's growth. Excuse me. So I find it's helpful to do cases. I've done this a lot with teaching when I teach medical students and others. And I think it's very helpful too in terms of trying to just sort of bring out some of the important things regarding growth. So I have a case here. So this is a story of an 8-year-old boy who's brought in for short stature. The family had moved to the area about a year ago, and he's shorter than all of the boys in his grade and a good number of the girls. There's been some bullying too, which we'll talk about and will tie in very nicely with Thomas's talk. Um, Also, dad is shorter than average and doesn't want, and probably had some of those same issues when he was growing up, and doesn't want his son to have to deal with those things. So again, like I mentioned, the first thing to, I think, appreciate is whether or not short stature is okay or not okay. Now, we can certainly debate socially differences in terms of stature, but the reality is that all of us have differences in terms of how we look, how, what our stature is. Some things about us are certainly more obvious than others, and stature and our appearance outwardly is probably one of the biggest things. The reality too is that people come in all sizes, and so family background really plays it in large role, an important part in terms of determining how tall someone's going to be ultimately. So the other thing too is, in addition to just looking at family, is that short stature also depends some on ethnicity and where you're located. So in the United States, for a man, the average height is roughly about 5'10". But if you're over in the Netherlands, for instance, they have tall stature, so 6 feet tall. Or if you're in Asia and Indonesia, shorter stature. So again, what considered to be normal really honestly depends a lot on factors such as your family, your ethnicity, and other prevailing issues as well. Um, Switching over and talking with the endocrinologist hat now, of course, when we look at growth, we really need to compare growth when we look at how someone sizes up compared to average. And so one of the things that I tell families is that while short stature is a lot of times relative, we do have some um, boundaries that we can look at. And so, short stature by a medical standpoint is really extreme short stature. So down at the very bottom of the growth chart. And again, this would be 5'4" or shorter for a man, or 4'10" or shorter for a woman. And of course, when we're looking at growth too, one of the things that's important is we need to look at the accuracy and documenting growth. And so for me as a pediatric endocrinologist, this is one of the most important tools that's going to help me out, is to have accurate, multiple points in time growth, so I can really evaluate whether a child is growing normally and seeing if he or she is falling further behind, or just sort of staying in their position, or maybe even starting to show some encouraging signs that they may be growing faster and gaining some ground. So really, again, for me, when I meet families for the first time, my primary question is there something wrong that's causing the short stature, or could this be some variation, in growth that's otherwise normal? Again, familial short stature would be something to consider. Also, children can be late bloomers, so they can grow slowly and then have catch-up growth later, usually around the time of puberty. But again, there are a lot of things that can cause negative effects on growth that are underlying health problems. And again, the primary concern for me medically is to try to identify if there is a problem, so that I can provide some insight for the family, and we can come up with a treatment plan that's not only going to help the height, but also help the overall health of the child that I'm seeing. So again, as far as growth, there's a lot of things that impact growth. The reality is that you have to blame your parents if you have short stature, because really about 80% just comes from genetics. There are a lot of genetics involved, and so at least 180 genes have been detected recently that have some impact on growth. So it's a lot of different complex genetics that really go into determining height. But there are things that do impact height, which can be changed. So things like diet, things like illnesses, which again is my primary goal, is trying to determine if there's some type of illness. And then of course, emotional health and well-being also. So again, a couple of things on John. So we have some growth points on him. We can say, yep, if we compare him to average, which is right here for boys his age, he's short and he's a little bit underweight too, but his height and his weight are fairly well matched. But again, the question is going to be, is he okay or not? And again, like I said, family height really plays a big role in terms of determining okay or not okay. And we know in John's case that there is some short stature. And again, there's a calculation that really helps a lot in terms of help giving me some perspective. And this is called the midparental height target. And so this is using parents' heights and basically averaging them, making a correction though. So for instance, if you look at on average, men are about 5 inches taller than women are. And so if we're doing boys, we add 5 inches to mom's height and average it with dad's height. Or if we're doing girls, we subtract 5 inches from dad's height and average that with mom's height. So if we do that with John, we can see that his height prediction is just shy of 5'9". So dad is shorter than average. He's 5'7.5", and mom is a little bit taller than average at 5'5" for a woman. So if we look at kind of where we would expect him to be, he's on the shorter side, because again, 5'9" or 5'8", almost 5'9" is right close to about the average point. So a little bit short, but we still don't really know, is he okay or not? So other questions that help me out as I'm beginning the journey of investigating is going to be asking the family, how long has he been short? And is he growing even though he's short? And how's his health and how's his diet? And again, looking at growth, the other things that I look at are going to be things, whether we're dealing with short stature or actually growth failure. Growth failure, which basically means you're dropping or plateauing, is very concerning. And that really, to me, raises alarm bells, and I need to try to figure out what's going on. And again, short stature can be impacted a lot by family, can be impacted by things like ethnicity, like we mentioned as well. And certainly nutrition and other factors and medications can affect these as well. For growth failure, again, these are the same things at play, but sometimes also stage of puberty, because if a boy or a girl for that matter is delayed in puberty and his or her peers are taking off and having their pubertal growth spurt, it's going to appear that this child is really falling behind, when in reality, it's their peers that are taking off and that gap is widening. So again, it's a lot like a race. You have, for growth, you have the people that are ahead and you have the people that lag behind. Sometimes, again, the question is going to be, are we seeing somebody that's lagging behind because there's a problem or not? And again, one of the tools that I look at, and again, kind of going back to the idea of the race, is how fast is a child growing? And so we can compare a child based on their age and their gender to what's considered to be average on their height, but we can also look at how fast they're growing too by same growth chart method. And so if a child is growing significantly below that average line, that's also to me an alarm bell that I need to get deeper into their medical history and examination and run tests to try to determine if there's something going on. And again, looking at John's growth chart, now that we've got more information, we can look at some of the growth points from the past, and we can see that John's not showing growth failure, nor is he really dropping in weight. And again, with more points, I can also do growth velocity calculation. I can say, okay, he's growing, and he's growing maybe a little bit below average, but certainly not down at the bottom. So maybe he's okay. But of course, the question a lot of times that people ask when they come is they say, does my child need growth hormone? And again, that can be a challenge too, especially in shorter stature situations. The other challenge too, and I'm in Texas, so I mean, a lot of people appreciate that we love our football in Texas. And so, especially boys, primarily boys that participate in sports, oftentimes sports tend to be advantaged towards taller stature. And so, some of the effects or some of the concerns a lot of times stem out of the fact that they're hanging around with taller peers. And so that magnifies again the difference in height. So again, there's a lot of medical reasons that you can see short stature. And so really it's a lot like detective work. So we're heading off into the great unknown, trying to figure out, is there a problem or not? And again, there's a lot of evaluation that goes into short stature. You can see a huge laundry list here. I put this up mostly just to kind of give you a sense in terms of all the different things that cross my mind and the mind of a lot of pediatric endocrinologists when we see a child with short stature. But again, we see, when we look at John's history more carefully, it's about 4 to 5 years. They're still buying new clothes and shoes, which again is a good way to kind of say, okay, this child is not failing to grow. He's healthy. He was not a small or premature baby. And while there's some shorter stature, there's nothing really particularly short in the family. Dad, also puberty and timing of puberty is very important. So dad feels like he was average. Mom had her periods starting towards the end of 9th grade, which would be, again, towards 14, 15, which is a little bit later on average than girls typically get their period, which is more around 7th or 8th grade or 12, 13 years old. And again, things seem to be going okay for him. He's eating well, it feels good, but some effects in terms of how he's feeling. So again, some of the tests and things that are done, probably the most important thing for me as I'm trying to get an evaluation on a child is a bone age x-ray. This is something that doesn't require blood draws or anything like that, and it's a simple x-ray test, but this allows me to look at the growth plates, which I have here in the hand. Every bone in your body has growth plates. It just happens that we have standards for our growth plates in the bone age book. And this basically allows me to determine how close is a child to finish line. So again, just as an example, here's a very mature bone age. So this again corresponds to the 15-year-old male standard. So here, this boy this example has achieved almost 97% of his final adult height. Whereas here's a 10-year-old who's only about 78%. So again, if you're short, you want open growth plates and you want a younger bone age. If you're here and you're short, that's very likely going to be your destiny in terms of your final height. And of course, the other thing too is not to forget about short girls. We talk about boys, but stature is still the same regardless for girls. And there are some challenges and implications for girls for short stature as well. Although socially, the reality is that short stature in girls is not as distressing as short stature in boys or men. But regardless, short stature in a girl can also potentially signal a problem and really needs to be evaluated as well. And again, one of the things that we think about, or I think about very strongly in short stature in a girl, is a diagnosis of Turner syndrome, which is a genetic condition. And again, there's a lot of health issues that go along with the diagnosis of Turner syndrome, in addition to extreme or more extreme short stature. And so it's important for families to consider the fact that their girl who's short may not necessarily be just cute and petite, but may actually have an underlying medical problem as well. So after taking that little detour, let's finish up the case and talk about John. So John had investigation done. He had his bone age x-ray done. And what we find is that John's got a delayed bone age. And so the delayed bone age again means he's further off from the finish line. So he's got the potential that he could get higher on the growth chart. The other thing too with the bone age is in the bone age book, there's a table that allows a prediction or an estimation of a final adult height. And so his predicted height based on his height point and the bone age at the time is 5'9". So this is actually very reassuring. While in the present he's short, at least the future forecast says that he has the potential that he could reach basically right about the height range that we would expect him to be based on his genetics. So adding everything up, and also with mom's history of being a little bit late in terms of her puberty and her periods, probably this guy's a late bloomer. And again, with no growth failure, that's reassuring. Now, that being said, it's still a challenge, no doubt, for this young man being shorter than average. And again, Thomas is going to talk a lot about bullying, but the reality is that bullying can take many forms. And if it's not one thing that a bully is going to target, whether it's height or appearance or clothes or things like that, there's a lot of those issues. So not to discount that. But the important thing for me medically as I partner and follow with the family is to reassure them and watch his growth for now. Because again, even though my snapshot in time says this young man appears to be healthy, excuse me, and appears to probably be a late bloomer, the only way to know that for sure is to continue to follow this young man and make sure that his growth does remain stable and potentially or eventually will begin to rise as well. So the question is, does John need growth hormone? Which again is still the question that a lot of families will ask. The answer at this point would be no. And again, we'll talk a little bit about some of the issues on growth hormone with our next speaker, Catherine Messenger. But there are some approved uses for growth hormone, and John at this point doesn't really fit in any of those categories. And so really the follow-up and observation in this growth is going to be the most important. So with that, I'm going to finish up. I'll hold questions until we finish up. I'm going to go ahead and introduce our next speaker. So we've talked about growth hormone, but the question, I guess, that many people will ask, and I think a lot of people don't necessarily understand, is about growth hormone. So again, growth hormone is one treatment or therapy that can be used for growth problems. The reality is, though, I guess the practical issues are with growth hormone. It's been around a long time now. We've had synthetic human growth hormone since the 1980s. And while there's been some progress in terms of how the growth hormone is given, and I think here very shortly some new innovations in terms of how frequently growth hormone will be given. Growth hormone is still given as a daily subcutaneous injection. And so with that, I'm going to pass the speaker to Catherine Messenger to talk a little bit about growth hormone and injections. And then she and I will kind of go back and forth a little bit and talk about some of the important points on growth hormone.
Thank you, Dr. Steelman, and thank you, the Human Growth Foundation, for the opportunity to present today. I am looking at hormone injections from the perspective in a practice, as currently our regimen has been anywhere from 6 days per week or 7 days per week, all according to what the provider feels is best for that patient. When you talk about compliancy, I look at compliancy from several different aspects. I don't look at compliancy as just as to whether or not the patient is taking the growth hormone according to how they should be taking it, but definitely by many, many aspects. Growth hormone in itself, requires lots of diagnostics to be done, And of course, with your insurance or your pharmacy benefit manager, it would be an authorization process as well. Sometimes it's a rather lengthy process before we get to the actual injection. And certainly, if there is a want, need, and desire, then certainly it is a therapy that is much desired at that point. And as Dr. Steelman was saying, we will have in the very near future an opportunity of having growth hormone given less times in a week. And certainly we are all looking forward to that. And possibly even, a new therapy on the horizon is going to help with some of our compliancy concerns as well. And when I talk about compliancy, I always look at the fact that there might be multiple family households. Who's the support system? Is there a support system? I always tell our patients in practice, you've got a team. Your team is going to be those folks that are going to be taking on the responsibility for giving injections. And certainly it's your provider, your pediatric endocrinologist, the nurse, or the coordinator for the growth hormone in the office. That's your team. Your team is going to be the one to support you. They're going to be the ones to, be that support system for you. Definitely, there are injection concerns such as, needle phobias and certainly, discomfort and some of the other aspects of that. I certainly always push and reinforce, a nice calming atmosphere, certainly relaxation techniques, certainly talking through to the level of the child, and certainly trying to get that caregiver, whoever's going to be giving those injections, to involve the child as well to the ability of their age, and certainly trying to get that involvement so you have that buy-in, so to speak, for those injections, whether they be, every evening or they be 6 evenings a week. Definitely some of our challenges would be changes in insurance plans and pharmacy benefit managers, changes in, loss of insurance. Unfortunately, during our time now, our last, year and a half, we've had a lot of families that have lost jobs. And unfortunately, we've had to be a little bit more creative in how we are still providing that growth hormone therapy. And then certainly we get into injection fatigue, which, is another whole subject on itself. But, I always reinforce that positive reinforcement and certainly, again, talking things through with the child, to the level of understanding, of course. But certainly there's a lot of aspects when it comes to compliancy with growth hormone. But certainly that's a bit of a jumping off. And certainly Dr. Steelman and I will be going back and forth a little bit with some questions. So go ahead, Dr. Steelman.
Well, let me ask you this. So, and forgive me, I'm about to say something, and I'm not implying you're old, okay? But I'm curious. You and I both are. I mean, I'll certainly say I'm a little bit seasoned when it comes to the time I've spent in endocrinology. So I've seen a lot of progress in terms of growth hormones. So what's been, do you feel like, the biggest progresses that you've seen in terms of the injections of growth hormone? I mean, for me, I recall back in the days where it was much more, cumbersome process. You had, 2 vials, you had a vial of liquid, you had a vial of powder, you had to pull it out, you had to mix the two, and you had to, carefully pull up with a little insulin syringe to give doses. I mean,
Absolutely.
And now, the devices that are used for growth hormone injections are quite a bit easier for families. And so I think that's been a big progress from my standpoint. I mean, what are your thoughts?
You're absolutely right. I think there has been a huge advancement in the growth hormone world. I can admit that it's probably 45 plus years since I have been in the endocrine pediatric endocrine field, and I honestly have to say, I remember the days of having growth hormone stimulation testing in the hospital setting, where you brought someone into a ward and you had 10 patients.
Mhm.
all came in for growth hormone stimulation testing. And the only thing we had available, you're absolutely right, was a vial and a syringe, and it was mixing medication. And as simple as that might seem, it's not always simple for everyone. So definitely having different devices, storage flexibility, where we do have some that don't require refrigeration. There are definitely some aspects that are great pluses for sure. But you're right. And I'm really looking forward to what is on the horizon. We've had
I agree.
devices that, have been out for a long time. And, I'm really looking forward to what's sort of the next generation of what's coming out to offer our
Mhm.
patients.
I agree. I think, certainly the devices are getting easier, I think. And certainly, again, as I mentioned in my talk, we have at least one long acting weekly growth hormone that's now out, and probably one or two others that will be following sometime in the near future as the FDA continues to review their application. So I think that's going to make it easier, certainly, to do once weekly versus once daily. What do you find from your standpoint is the biggest challenge in terms of staying, focused on doing the injections? Are there any tips or tricks that you offer families to help them to sort of continue that grind, especially after maybe they've been doing it for several years?
I think, again, it's been more of that trying to reinforce the benefit, certainly, when we're looking at linear growth, certainly showing them charts and certainly keeping them hopefully motivated. And gosh, we're still on that upward climb. We're still getting benefit at this point, and certainly trying to, give them some sort of, hope as far as any comfort that there might be, associated with it. Obviously, needle phobias are something that we deal with all the time,
Hmm.
and I believe that we come to the point also where our needles are finer, shorter, smaller. So much easier to use. We have got covered, needles that are covered that we can use as well. We've got needle guards for some of our devices. I definitely believe that, there are so many things that can be done. As I said, I work with, patients all the time and say, gosh, let's do some relaxation techniques. Let's do, perhaps if we need to ice an area before we get an injection first,
Hmm.
using the smallest needles possible. All of those aspects. I think probably the hardest to deal with is the fatigue, when
Hmm.
it has been a long time. As I said, I think it's just that positive reinforcement of look where we were, look where we are now, and look where we're going in the future,
Hmm.
to try to get them motivated. It started young.
Do you have anything? I mean, for us, we have a child life specialist that helps a great deal in terms of the procedures that we do in our clinic, and also they can help too with an injection um, challenges. If you have needle phobia, and that's not only, you mentioned needle phobia. Needle phobia is not
Mhm.
just something that you see in kids, but we've had parents where that can be a significant mountain for them to have to climb too. What's been your approach in dealing with children and families where there is significant needle fear?
I honestly have to say, I will bring out those examples. I will show them what is going to be available, have their input, definitely have them involved in the decision making. But definitely, you're absolutely right. I probably find that the needle phobia is more so for caregivers and parents sometimes, than it is for children, and sometimes that's based on previous history. If they've had injections that didn't go well,
Right.
that's where some of the needle phobia comes in. So it's really talking it through and showing them the actual examples, where when they see them, they usually go, oh yeah, that's not so bad. That's not what I recall.
Hmm.
Certainly, it's just that, again, that positive reinforcement. I think it's great that you've got a specialist that's able to work with them, In the office setting, we, don't have that luxury for us. But I definitely have to say that it really is more positive reinforcement and actually showing them what's available and having them have some input on choices at that point.
So one thing too, you had talked a little bit again when we were talking about the good old days. You were talking too about, doing testing in the hospital and things like that. So it just made me think too that I think, a number of our audience, if they're medical background people, might sort of know, or if they've been through the process themselves. But just for the benefit of people that maybe don't know. So again, I mentioned at the very end of my talk about growth hormone, and there's a number of different reasons that growth hormone can be prescribed to children. So very seldom, do I have someone walk in where I go, there's growth hormone for you. So it's a process, but one of the steps in that process, particularly with when we diagnose, low growth hormone or growth hormone deficiency, is stimulation testing. So tell me a little bit about how you all are approaching stimulation testing in the modern era now.
So I think that there has been some various approaches. I definitely will say that there are facilities that still are using the gold standard of stimulation testing. And that basically consists of bringing a child into either an outpatient setting, or if they are using a hospital setting or using an infusion center perhaps, and they will be doing, periodic blood testing and definitely be giving them some agents for the stimulation part. And it's usually several hours. There are, children that react well sometimes and are not feeling so well from the agents that are used. It may consist of having an IV, obviously it's dedicated time of those blood draws that are being done. I will say in practice in our facility, to be perfectly frank, we have not been stim testing for quite some time, but again, that's not saying that is not the gold standard. We, have not much difficulty with approvals, but I do believe that that's based in part from the types of insurance, plans that we're having as well. A lot of our managed Medicaid plans as well don't necessarily need all of the information. As long as we're doing blood testing and we're doing MRI, we're doing bone age, we're doing growth velocities, those sort of things seem to hold weight, as well as the indication for growth hormone. There are indications such as Turner syndrome that you alluded to that don't require us to do stim testing. SGA, small for gestational age, does not require us. So certainly there are those diagnoses that we do not have to do stim testing, but for pure growth hormone, deficiency, that is still considered the gold standard.
Right. I definitely, that's our experience as well too, that there are some situations where we don't have to do testing. When we do testing though, it's, it can be a process. And I think, a lot of families don't appreciate sometimes how long it can sometimes take to arrive at a diagnosis, particularly for growth hormone deficiency, if there's no obvious, clinical clues that point us in that direction. Sometimes there are, and again, that's the importance of knowing medical background and things such as that. But again, it is a process for me, like it I guess to go back and talk about the theoretical case of John. John had been failing to grow, and his investigation had looked suspicious for growth hormone deficiency by the screening test that we do. Then the next step ultimately would have been at some point to do growth hormone stimulation testing, which is a uncomfortable procedure that requires, in our case, it's done in our clinic in an outpatient setting, but it takes about 4 hours of time with monitoring and with the nurse there to evaluate him. And then, if he had failed the growth hormone stimulation testing, then an MRI scan of the brain looking at the pituitary gland, specifically where, growth hormone is made, to make sure the pituitary looks normal and there's not some problem that we've been able to uncover with the pituitary gland. And then after that comes, the approval process for growth hormone, which is, unfortunately, as you know, not always the easiest of propositions either. The reality is, with all medications, there's cost, and growth hormone is, with the process of manufacturing other things, is isn't a more expensive injectable medication. So insurance companies tend to be very aware and have very strong, strict processes for getting someone on growth hormone treatment. So for me as a physician, I think I have to make sure that I really have my ducks lined up in a row, and also and know that I have a certain diagnosis and believe strongly that, the child needs to be on growth hormone treatment. Because again, sometimes, myself and I don't know what your experience is as far as having to deal with appeals, if insurance says no to growth hormone. So sometimes we have to put on the boxing gloves and get in the ring with the insurance company and box it out to get children and families the therapies that, I feel like they need. So I don't know what your process, what your experience has been as far as that process, and certainly if you do get a denial for growth hormone coverage, what your appeal process is.
Yeah. I have to say, Dr. Steelman, over the years, we would look at a particular case and look at all of the diagnostics and be able to say, well, this is a slam dunk. We know that we're going to be able to get approval, no problem whatsoever. It's very interesting how insurances and pharmacy benefit managers now have changed their criteria. And if you don't have every check mark in the box, it's immediately denied. And then the appeal process becomes a very grueling process. There are internal appeals, there are external appeals. There are things that you have got to read every single letter on that correspondence that comes back to you to the office, just to know how you need to proceed. If you don't proceed in the right way, then there is no appeal to go through.
That's right.
I think I find as of late, unfortunately, appeals now you've got to make sure that it involves the parent or guardian or caregiver that has to sign to say it's okay for we, the provider, to seek the appeal. And until they get that, they're not going to even look at anything. So they've made it much more challenging, much more difficult. And as you said, I think it's, again, cost is the greatest factor in, that approval process. So I always say, and the patients that I have in the office, I honestly say, when I get that approval, it's like I'm giving them an immediate phone call and saying, okay, we've got the approval. This is a good thing. We got to move, we can move forward now. But as you were saying, it's time consuming. There's a lot that goes into it. Peer-to-peer reviews are absolutely not pediatric endocrinologist to pediatric endocrinologist. It would be pediatric endocrinologist to maybe the internist who's on call.
Or a pharmacist sometimes.
Or the pharmacist, it's a very challenging situation. I find that it's a much different time right now. And, you hope and pray that it gets better. But, again, it's just a huge challenge.
It is. It's one of those things, I think, that, when you and I started in healthcare, we may not have ever anticipated that would be one of our things that we would be doing. We're like, oh, we're just going to be taking care of patients. But, there's a lot that goes on behind the scenes. And again, I think that's just speaks to the importance of, trying to be very methodical and thoughtful about, making decisions on how to investigate and how to go forward.
Yes, absolutely. I agree.
I did want to ask you one question too. We were talking a little bit about needles, but there are there have been, and I think there still is, a needle-free injection option. Any thoughts on needle-free injections? I mean, there was a lot
So
of
that's a great
promise, I think.
question. Yeah, that's a great question. I would like to say to you that it is my understanding that currently the needle-free device is not being offered at the moment. And I do believe there have been, and I don't believe that this is not information that's not available, but I do believe there have been a recall on the needle-free device. So
Okay.
again, I don't know that there's an option out there at the moment. But again, I think utilizing there is an auto cover needle, there is, definitely availability of, covered needle to use as well. I think, which is a great choice. Definitely, our 32 gauge, 4 millimeter needles as well are a wonderful choice. So again, I think, when you look at what is available out there, I think the needle phobia, once you've shown families or caregivers, those needles, I think that there's much more comfort in that there is some availability.
I agree. I mean, I think growth hormone, again, not to minimize injections on growth hormone, but it becomes much more of a challenge, I think, for me personally, when I deal with type 1 diabetes and the number of injections needed there, and trying to move it through with the families and with the children or teens, needle phobia in those cases, because there is, very little wiggle room about the injections that are necessary. And unfortunately,
Absolutely.
as with insulin, you can't take growth hormone orally. The stomach acids will destroy it. And so the same thing with insulin. So there's no practical way we have right now to give growth hormone or give insulin for that matter, except by injection underneath the skin, what we call subcutaneous injection.
Absolutely.
Any final thoughts that you want to add? We have a few questions for you that are at the end too, but anything else you wanted to add before we transition and to the next talk?
I think again, just really thinking about, all of those aspects of giving injections. I really do always tell my parents, to do simple things like keeping a calendar, and for your younger children, keeping, perhaps smiley faces or sad faces if we didn't do as well that evening, with our injections, but to kind of at the end of the week use a reward system depending on age of the child. Of course, with the older kids, that is much more of a difficulty to do, but certainly with your younger ones, keeping the calendar and kind of looking at it and saying, okay, we got our injection, we did well, at the end of the week, let's have some reward. I think that is a really great positive reinforcement. I tell folks all the time too, to set an alarm on their phones. All of us seem to have cell phones that we can set an alarm. Set an alarm to say, take that medication out of the refrigerator if it's refrigerated, a 15-minute alarm after that to give the injection, and then, to put it back into the refrigerator. So we make sure that we're, maintaining that, potency of the medication as well. I think it's just those kind of tips and tricks and, just a really positive, calm demeanor and, calm atmosphere. I think it's almost like sometimes, staging like you would selling a home, it's kind of staging things at home.
Right.
Do we have that comfy area of the couch where we have our blanket that is comfortable, and do we have a stuffed animal that we want? And, I found that, the iPads have been a wonderful boon to, saying, okay, let's put the favorite video on, while we're doing the injection. Singing, there's so many different things that you can do, again, with younger kids. You can't get away with it as much with the older kids, but, with the younger ones, definitely setting that firm, safe environment. I think that's the important part, that safe environment for them when they're starting with injections, and positive reinforcement.
It sounds good. A lot of those techniques you mentioned are things that our child life specialist uses. So,
Mhm.
well, thank you very much. If you'll hang around,
Thank you.
we'll finish up and have a panel discussion at the end, and I'll go ahead and segue in to have Thomas join us here. You're going to fix all of our bullying problems, right?
Uh,
Absolutely. Can you guys hear me okay? Everything good, Dr.
I
Stillman?
can. That's a fancy microphone you've got there.
Absolutely. I've had to learn from the kids that I serve how to bring myself up to speed and with all the latest technology so that I could effectively do virtual sessions like this. As you can
Mhm.
see, I have a cozy office in the background. So this is where I do my work throughout the day. So.
Yeah, that's been, I mean, just before, not to derail you, but when in the height of the pandemic a year ago, I mean, we had to really lock down and go virtual in terms of our medical visits. And we still, unfortunately, have a fair number of virtual visits, for some of our medically fragile kids that are just, we don't feel that it would necessarily be safe for them to travel or to be exposed. Some of them don't have or are too young yet to have vaccines. But anyway, we've really had to move, and I know mental health for sure has had to move a lot to virtual, and that seems like, that's probably going to be the here to stay at some level, I think. So that's maybe one silver lining in the whole experience.
Right, right. Well, I'm grateful for being able to connect with people this way, that we have the technology to do this. It was incredibly advantageous for the people, especially during the lockdown, for me to still be able to connect with them and help
Mhm.
them with their mental health needs and increasing mental health needs because of the whole, it's been 2 years, right? Seemingly.
Yeah.
We thought it was going to be 2 months, but it's been 2 years. So I guess
Hmm.
we can improvise, overcome, and adapt. So. Well, I'm so grateful to hear. I'm good to go and go into the lecture if you guys are good. If you had anything
Sure.
else.
I think we just about stayed right on time. So the floor is yours. So please tell us how to, give us your perspective on bullying, a problem unfortunately as old as time, and certainly with children with height differences can be, an extra source of opportunities for bullying.
Absolutely. Just height, and physical stuff. That's just one of the many things that kids bully each other about. And this is true. Like you said, Dr. Steelman, this is a pervasive problem that's as old as time. I mean, and it's not going to be eradicated anytime quickly. So hopefully during this talk, I can kind of illustrate what it is and what it looks like and how we could intervene and help. Because I think if we can attack it from a different perspective, then we can sort of build and bolster self-esteem and self-efficacy, especially for the young people. I'm a private practice therapist here in Vero Beach. Half of my practice on a weekly basis is spent working with children, adolescents, and young adults. And so bullying has been a pervasive problem that I have to address. And I wanted to offer two things in particular today, two negative core beliefs. And these are two negative core beliefs that I work with on a daily basis with the people that I serve, not just children, adolescents, or young adults, but also adults and even in elderly. These are pervasive problems that attach or are learned early on in life and sort of become this underlying narrative that we have to deal with. One of those is, I'm not good enough. Who knows where it exactly came from? It could have been when you were in kindergarten and you were coloring that Christmas tree purple, and the teacher said, um, "What's what's that? A purple Christmas tree? Christmas trees are green. It's not purple." Just that little thing, as insignificant as it may seem, could have potentially made that person not want to color or engage in art or feel like they just were not good at doing art for the rest of their lives. These things that are in our environment, these interactions that we have with people, we can start to form these negative core beliefs. And then we don't even realize how it's affecting our ability to perform, our inadequacies come out of that, and our poor self-esteem or low self-efficacy. Bullying in particular, that's the topic we're going to be talking about today. First, it's a label that I try to steer clear of using labels in the work that I do, or I just change the language, so to speak. So somebody may be bipolar, but instead of saying they're bipolar, I'll say that they have bipolar. They may be depressed, but I say, hey, you have depression. You're living with depression, or you're living with anxiety. Even somebody, if they come in with diabetes, they're a diabetic. Of course, we know this. But if I change the language, well, you're living with diabetes, and how can we manage that? How can we help you manage those things? Just managing the symptoms. So the negative core beliefs, I'm not good enough. There's something fundamentally wrong with me. And out of that comes a need to overcompensate, maybe sometimes narcissism, a need to dominate others or control, and of course, poor self-esteem and inadequacies. The second negative core belief that I really work with and attack here in sessions is the person who thinks and believes and feels that they don't matter. And this is the type of person that feels, maybe because of neglect, maybe because mom or dad was an alcoholic and they didn't spend the time, or they were out partying, or maybe they were divorced and they feel like they were partly to blame, and then they're bouncing back and forth. They feel like they just don't matter, and then that permeates through the rest of their lives. And these people tend to focus their attention on other people, because if you feel like you don't matter, then why would you focus on yourself? Let me focus on other people. In particular, let me help other people fix their own problems, and they don't work on their own stuff. So they in turn as well have poor self-esteem, and they tend to give away their time and energy for other people, and they usually end up developing some sort of codependency too. And oddly enough, we find a lot of people in the helping profession, clinicians, social workers, nurses, aides and whatnot, sort of coming from maybe an I don't matter. Um, I'd be the first one to admit that I have been bullied before, and I've also bullied somebody. I'm not happy about that, but I think we are all guilty of being bullied, and at some point in our lives, even if it was very subtle, of bullying somebody else. So instead of saying and labeling this person as a bully and they're bad, they're not good enough, and this person is a victim, we want to remove some of those labels and look at, okay, well, what's going on in their lives? There's definitely a reason for it. Just like all of our feelings come from something that some kind of thought that we had, and that our behaviors are coming from how we were feeling in the moment. So there's always a reason. We can always trace it back. In session, I utilize cognitive behavioral therapy, which works really well with adults because of their cognitive processes, but with younger people, as the prefrontal cortex is still developing, even before age 24. So sometimes cognitive behavioral therapy only goes so far. So I have to use other more fun interventions like hypnosis, and in particular EMDR, which is a mouthful, eye movement desensitization and reprocessing, but we just say EMDR. But this enables us consciously to target some of those distressing and even traumatic things that have happened in our lives, especially when I did not feel good enough or when I felt like I did not matter. So I'm not good enough and I don't matter. Those are two important things that are takeaways for today, because if we can focus on and see people as potentially having one or two, or maybe an amalgamation of these two things, I'm not good enough and I don't matter, we can sort of help to bolster self-esteem. We can help people with distress tolerance. We can help people identify some positive coping strategies instead of maladaptive ones. Well, let's define what bullying is. It's any unwanted aggressive behavior or behaviors by another person or group of people that involves an observed or perceived power imbalance and is repeated multiple times or is likely to be repeated. Bullying may inflict harm or distress on a targeted person, including physical, psychological, social, or educational harm. And there's a couple different ways in which people who are bullying engage in that type of behavior. There's direct and there's indirect bullying. Direct bullying is those aggressive behaviors that occur in the presence of the person, like excuse me, pushing and hitting, direct harm, written or verbal communications like taunting and mean notes. And then the indirect bullying is where the aggressive behaviors are a little more subtle. They're not as out in the open, but they're like spreading rumors behind their back or telling other people to exclude this person, for whatever reason. So there's different types of bullying. There's physical, there's verbal, and there's relational. Um, uh, so the physical is, of course, like I said, hitting, kicking, punching, spitting, tripping, shoving somebody into a locker, there's verbal, like taunting and name calling, threatening words, notes or gestures, even sexual comments. And this is very disturbing because I've been noticing that earlier and earlier during the life stages. I mean, kids even as young as like 8 and 9 engaging in explicit sexual comments and harassment to their peers. And that's incredibly disturbing to me. And then the relational is designed to harm their reputation or their relationships with others. So like social isolation, spreading rumors, and even posting embarrassing images. Posting embarrassing images is kind of disturbing as well because of the lockdown and how we've gotten into social media. And of course, with technology, I mean, every one of the kids, even kids that are, 7 or 8, they have cell phones and they're on Snapchat and TikTok. And they don't, of course, I'm old, so I use Facebook, but they don't use Facebook anymore. But they're engaging in this almost like seemingly all day long and all evening long. And so the images are out there of how to look and how to dress, and you're not okay or you're not part of the crowd if you're not doing these things. And so these are suggestions that are being blasted at the younger population, all of us, really. I mean, marketing does this really well. And so they're able to take pictures, and kids are so adept at using like Photoshop and video editing software and things like that, with the YouTube videos, that they're capturing these images and they're using that to cyberbully. And cyberbullying has become so intense as of late. It just keeps increasing and increasing, which is so much different from the face to face because, face to face, you get called fat or a bad name or ugly or stupid. And when you're in the presence of that person, it's harmful, but it can kind of go away a little bit when you leave school. But when you're pulling up your phone and there's something that's written in one of your on one of your accounts, and maybe even a disturbing image where somebody used Photoshop, that's out there forever. That's there. You're always going to see that, and other people that are part of your accounts are going to see that. The cyberbullying is something tremendously harmful that we have to find some better ways of attacking that. And I don't really have the answer for that, but at least face to face, we can come up with some solutions to improve the people who don't feel good enough and also who don't matter. There's a lot of kids that are bullied. I mean, between the ages of 12 and 18 during school years, like 22%, and probably even more now, these numbers are probably a few years old, are bullied in school. And a little bit less, but about 20% of high school students were bullied. So this is actually happening and is more pervasive for the middle schoolers and then the elementary school kids. Very disturbing. They're being made fun of and called names. They're being insulted. There's rumors they're being physically pushed or shoved or tripped. They're excluded from activities on purpose, even threats of harm. They're forced to do things they don't want to do. Some of their personal property or personal effects have been destroyed. And then, of course, the cyberbullying. These are just some ways that people who bully gain control or gain dominance because they themselves don't feel in control or don't feel like good enough. So they have to do it to other people, usually people that are perceived as being weaker, who have some physical issues or disabilities or impediments or something that they can pick on. And kids are mean; they can find all kinds of things to pick on you about. Boys and girls, just a little bit different. I mean, of course, in any arena that we discuss, there are some differences. So boys are probably more likely to bully others and bully each other. And then it's more physical in general, where girls are more likely to be bullied through the rumor spreading or name calling or exclusion, and of course, cyberbullying. Um, there's some differences in the ages, like I said, where to highlight again that it's not so much high school, but more middle school and elementary school. And the majority of people who are bullied, of kids who are bullied in school, they don't tell anybody about it. They don't go to a teacher or a school counselor and speak up for themselves. Sometimes, more often, they'll tell their parents, but they don't report it, especially boys, especially older boys. They just don't report those kinds of things. There are some risk factors that I want to talk about. There's the individual person and their temperament, how socially competent they feel. If there's any alcohol or drug use, which is definitely happening in high school, even the vaping too. I mean, that's become a huge thing, not just in high school, but also in middle school. Kids running off to the bathroom and vaping. So when you have drugs on board, anytime you have drugs like alcohol and illegal substances and marijuana pens and vaping devices on board, it throws a wrench into everything. And they develop this maladaptive way of coping with stress. We've all been under a tremendous amount of stress lately, and so we see how that's acted out in the schools. If they have a disability, any type of disability, be it a physical disability or a learning disability, that may lead somebody to point that out and bully them or socially isolate them because of it. Also, sexual orientation. That's been a pretty big topic as of late, especially when kids are feeling like they want to identify as a different gender, or if they come out as being gay or questioning or even transgender. These are subjects for people to bully them about. Um, there are peers who are exposed to aggressive and violent behaviors from other peers, and that can be very traumatic, just that vicarious trauma of witnessing those things. So even if they weren't either the aggressor or the victim, they still suffer from that. And most kids that I talk to, they at least have, if they have not been a target of bullying, they at least have a close friend that has experienced that. Then we look at the families, because I look at the person in their whole environment, and there are some family factors that are involved in bullying. Maybe a lack of parental warmth and engagement. There may be parental conflicts going on at home, and the parents may use drugs or alcohol, and there may be domestic violence, and all these things can factor into the person, well, one, not feeling good enough or not feeling like they matter, and having a loss of control and feeling like they need to gain that control by having control over other people. Parents being in jail, or maybe even abuse happening at home. These are some things, excuse me, that lead to bullying types of behaviors in order to regain that sense of dominance. There's some factors in the school that may lead to bullying, the climate of the school, whether or not the kids feel like a sense of belonging to the school or pride in the school, their degree of respect, and if they feel like they're being treated fair. If not, that could lead to, bullying types of behavior. If there's not adequate teacher or faculty or student or adult supervision, and awareness and responsiveness of the staff to attend to the bullying types of behaviors. I mean, a lot of teachers now, they pretend like it's not happening. They're focusing on their classroom stuff. They're trying to keep kids in line. They're trying to make sure they attend to all of their criteria for that class and for that semester. And so they're focused on that, and they're not focused on the bullying, because it takes a lot to separate and try to deal with. There's some community factors too. Think about the safety of the neighborhood that the children are in, and how connected they are to the neighbors or to the adults in the neighborhood. And is there an atmosphere of promoting good enough, or do you matter? to the people in the neighborhood, or is there this constant you're not meeting the expectations, or there's something fundamentally wrong with you, and that leads them, of course, to internalize and not feel good enough. There are protective factors too that I want to discuss. So if we can focus on these for a moment, and you can assure that you're meeting these, then this can decrease the amount of bullying and also increase and improve the amount of self-esteem and self-efficacy that the kid has in their environment at home. um, do they feel secure? Do they feel cared for? Do they feel self-confident? Do they have supportive parents? Are the parents modeling positive relationships and what that looks like? It's really important for parents to model the appropriate behaviors that they want. So if the parents are stressed and how they act out is by screaming and yelling at each other and putting each other down and calling each other names, moron, and then somebody throws a dish across the room, the kids are picking up on these things, and this is how I need to act whenever I'm feeling stressed. This is what I need to do. I need to put somebody down. I need to throw something. I need to be violent. If there is consistent and affectionate bonding between the parent and the child, that's really good. That's a protective factor. At school, if they have close, positive friendships with peers, that's really good. If they engage each other, and the teachers are engaging and they're responsive, and they're more inclusive and nurturing, and they promote that atmosphere of and focus on their strengths. I think a lot of this revolves around being strength based and focusing on exploiting and encouraging the person's strengths for who they are instead of pointing out their defects of character or what they're not doing. Point out when they're doing good, catch them doing good, and express to them that I like that because of the goodness of you as a human being, that you are good. There are some community factors too that are protective that help out. If we have cultural norms and beliefs that are pro-social and non-violent, if we deal with things in a more professional way, like sticking to the social contract, so to speak. So, for the good of the community, we do these things. That could be helpful. If there are some positive adult child connections in the neighborhoods, and if the neighborhoods are safe, these are protective factors. And so think about all these different factors that are both risk and protective that are affecting us just as adults on a regular basis, and how they're potentially affecting our children and the children in our neighborhood. I've touched on it already, but let's just briefly run through again the young people that are at higher risk of being bullied. These are kids that have learning disabilities, maybe that have ADHD or ADD, kids that are on the spectrum. If they have special healthcare needs or chronic diseases, such as having diabetes, if they're overweight or if they're underweight, if they're lesbian, gay, bisexual, or transgender, if they're questioning their sexual orientation or do not conform to gender stereotypes, they're at risk for being bullied. And also cultural issues too. So maybe they speak a different language, at home, and they speak both languages, or they speak a mix thereof. They're kind of perceived as being different. So doesn't necessarily mean if the kid has these issues that they're going to be bullied. It's just something to look out for. It's just another risk factor. These are how kids who are being bullied, how they're effective. Being bullied is usually associated with later them internalizing problems. It can lead to some mental health issues like depression, anxiety, panic disorder, self-harm, suicidal thoughts, and even suicidal attempts. And did you know that, and very disturbing statistics, that over the past 30 years, suicide attempts have gone up related to kids that were bullied by 50%. I think that's just staggering. It leads to psychosomatic problems. So not only are they having some mental and emotional issues, but they're starting to notice some problems in their body, having headaches, dealing with the stress of being bullied, stomach pains, usually coming from the anxiety, sleep problems, and poor appetite, and the need to maybe even self medicate or self harm to kind of deal with these things. We notice academic problems, and then externalizing behavior. So, them bullying themselves, as an attempt or as a maladaptive way of coping with it. There are some biological mechanisms that are associated with bullying. They have noticed in neuroimaging studies that the body's stress response system have shown to have harmful biological changes because of and directly related to being bullied. Being bullied affects the body's stress response system, which can affect academic outcomes as well. Other biological mechanisms associated with bullying are these individual scars that bullying can leave. It's important for us to promote well-being of our children and adolescents and young adults. There are some concerns for children who bully. These children and young adults or anybody who bullies, they're more likely than their peers to exhibit antisocial or delinquent behaviors such as fighting, stealing, and vandalism, engaging in criminal acts. They may dislike school and drop out of school. They may drink alcohol and smoke cigarettes or vape. They may even carry some sort of a weapon, guns or knives or something that can be used to physically harm someone. They themselves even think about and attempt suicide, remembering that it comes from that feeling of not being good enough and needing to control or dominate somebody else. And they may even come from homes with intimate partner violence or domestic violence. There's concern, of course, for these children and young adults who bully because of the criminal aspect and the antisocial behavior that doesn't go away or get better. It's much more difficult to address that later on in life, after the formative years where these behaviors and these concepts have been learned. They maybe perpetuate sexual harassment and maybe even engage in sexual misconduct. Once again, I said that most of the kids just don't report. They don't tell school personnel about being bullied, but they may tell their parents. And the younger they are, the more likely they are to tell their parents. But as they get older, as they start to develop their sense of self and their ability to interact with the world, they usually are reluctant to report any types of bullying. So the real statistics and numbers that we have are probably not accurate. Um, there's reasons why kids and young people and even us don't want to report being bullied, because there's negative messages about being a tattletale or being a snitch. They're worried about being retaliated against. There's gender stereotypes, and there's lack of confidence in adults' actions with regards to when the kids tell them they're being bullied, nothing really happens. So why would you continue to report it? Other peers' attitudes and responses to bullying. Most kids and young adults have negative feelings about bullying. They feel sympathy for the bullied peers, and sometimes if they do intervene, it helps. 90% of elementary students said they felt sorry for students who are bullied. Sympathy is somewhat greater among the younger children and especially with girls, but it doesn't necessarily translate into action. But when they do try to help, they're usually pretty successful at stopping it. So it's important to at least try. School districts and the federal government, they issue laws regarding harassment and regarding bullying. And sometimes the school districts, especially in Florida, they don't always adhere to federal civil rights and federal guidelines. I mean, peer harassment based on a race, color, national origin, sex, or disability as a sufficiently serious issue that creates a hostile environment. And if that harassment is encouraged or tolerated or not adequately addressed or ignored, then this is a big problem that we need to address. So part of the work that I do is working in the community and working with the school board, and working with agencies and the police and sheriff's department to educate people who can make decisions, especially in the school board, to offer trainings and to remind them of their responsibility to the bullying epidemic and to harassment. They've tried many different ways to address it. That I think we're coming up on the break, so my apologies for running over time a little bit. Um, but I think if we can attack those first two things I talked about, I'm not good enough and I don't matter. If we can promote the idea, the more positive cognitive core belief that I am good enough and I do matter, and if you can see people as potentially having those and seek ways to bolster those positive thought processes, then I think we have a fighting chance at decreasing it enough that people can be productive and upstanding members of our society. So please hit us with questions later on. I'll be around and happy to help. Thanks again.
Sure, thank you. There's a lot of questions that I came up with while I was listening to you. So definitely, when we get to the panel discussion, we'll love to hit you up and of course see what our audience has to say as well. I hope you all had a chance to stretch your legs for the break, and thank you again to Pfizer for being one of our sponsors. I'm going to go ahead and kick off the back half of our program by introducing one of our board members, Dr. Juan Otero. Dr. Otero is with Arkansas Children's and is a pediatric endocrinologist. He's going to talk to us today about puberty, primarily precocious puberty.
I want to thank the Human Growth Foundation for the opportunity and for all the attendees this day. So as Dr. Stillman said, I'm going to be talking about puberty, specifically early puberty. We're going to focus on that and try to understand when that can be an issue with growth and development. All righty. So to, I guess, give you guys an introduction about puberty, I do want to say that puberty is a normal, expected process of development that when it happens within a normal timeline, pretty much is part of what is going to get us to the healthy, normal growth that we expect, understanding that there are going to be obviously variabilities in, height, growth, development, as adults. But as I said, it is a very important process during puberty. I'm going to be talking a little bit about what happens, but just giving you, I guess, a little bit of context. It's an important time for growth hormone production, for our sex hormone secretion as well, which all of those are going to basically contribute to the physical and also cognitive, psychosocial processes that happen during puberty. So to define puberty, which I think it's important to start with that, is a period of physical maturation, typically, generally speaking, the transition from childhood to adulthood. So majorly what we're going to be seeing is that physical maturation, but we cannot obviously forget that we are also going to be going through, cognitive and psychosocial maturation as well. So even although the major visible signs of it are going to be physical, it also involves psychosocial and cognitive, parts of it. The most visible changes, as mentioned there, are going to be growth and the development of secondary sexual characteristics. We're going to be talking about that, but that's basically how we're going to, focus on when to identify early puberty. So based on, changes in the pattern of growth or changes in the pattern of development of those secondary sexual characteristics is how can we identify if our kids may be going into puberty too early, or if maybe they're actually just following the expected pattern. And what is nice about puberty, generally speaking, is that it follows a predictable pattern. So you kind of like can base, again, your judgment or your observation based on that predictable pattern. And if something is out of that predictable pattern, then you can actually try to identify if there is something going on with our kids. So a little bit of, biology just really quick so that we introduce a few, words that we're gonna briefly touch on. From a, biology standpoint, puberty is initiated actually in our brain. We have a small gland called the pituitary gland, which is represented there by that purple area, which basically produce different hormones. Actually, in the pituitary gland, as you guys heard before, is where we make growth hormone, some other hormones, but for this specific topic, we're going to be talking about LH and FSH, which are the two hormones that actually help us initiate puberty. Those hormones in girls, ones that go to the ovaries and help us start that process of estrogen production, which is the hormone that actually gives that the visible patterns of puberty in girls, like it's going to be breast development, menstrual cycles, and the growth spurt. And then in males, we have same process happening in the brain, pituitary gland making those two hormones, LH and FSH, but then in males, obviously the LH and FSH will go to the testicles, which then are going to start making testosterone. And if the testosterone is going to be the one giving us the visible patterns of puberty in boys, which are going to be mainly testicular enlargement. So the size of the testicle starts getting larger and larger. The size of the penis starts getting larger and larger as well. And they will also contribute with the growth spurt as well. So remember, I was telling you guys how puberty happens in a predictable pattern. So as you guys can see from childhood to adulthood, in the cartoon, in the image, basically you can see how basically, physical changes like breast development, pubic hair, growth happen in that sort of pattern where you expect that they will continue to progress, breast development, meaning like the breast will get larger, pubic hair, meaning like it will go from obviously no pubic hair to having the pubic hair, quality and amount of the adult characteristics. So that's what's nice about puberty, and that's how we can identify, as I said, if there is any abnormality on how things are progressing based on that pattern. So in girls, I just want to mention a little bit about what's the normal sort of like sequence of events during puberty. So the first actual sign of puberty in girls is going to be breast development, okay? So breast development happens in average around ages 9 to 10, but it can happen as early as age 8. And I'm going to comment on that in a few slides. We're going to talk a little bit about some differences between ethnic backgrounds, but this is just, as I said, a general sort of like approach to it, where like breast budding is expected to happen around age 9, 10 in average. And then typically following that predictable pattern, we will expect also in average that the first menstrual period is going to happen about 2 to 2.5 years after the appearance of breast budding. And then completion of puberty, generally speaking, it's going to happen around 3 to 4 years after that first appearance of breast budding, which is in the medical world, we call that thelarchy, which is again the first sign of or onset of breast budding. So typically about 3 or 4 years, that's when puberty is going to be completed in girls. So following that expected pattern, again, in clinical practice, that's what we sort of like keep an eye on, watch for, and kind of like, I guess, based our judgment of whether things are happening in a abnormal pattern. There are going to be, you know, some differences. Obviously, each person is different, and sometimes, you know, menstrual cycles can happen a little bit earlier than 2 years, or the girl, or they can happen a little bit later. There are many factors that can influence how that happens. But as I said, you know, basically within that timeline is what we're going to be, you know, keeping an eye on. And then for males, the same concept. You can see from childhood to adulthood how physically we mature. We see basically, you know, more muscularity, more pubic hair, enlargement of the genitalia, those type of things. And that's what we're going to be keeping an eye on. And then, so the same as before, just basically sort of like what's the sequence of events, but this, in this case for males, the first sign of puberty in males is going to be testicular enlargement. We call that gonadarchy, and it's just basically how we kind of identify if a male is actually in true puberty. Again, in average, this usually happens around age 11 to 12, but it can happen as age 9, as early as age 9. And again, we're going to talk a little bit about where those numbers come from. And then typically 2.5, 3 years later, after initial testicular enlargement, you're going to see the growth spurt in males. During those years, you're going to see more pubic hair coming out, enlargement of the, or I guess, bigger size of the genitalia, including the penis. And then about 3 to 4 years after that initial testicular enlargement is when most males will have completed their puberty and will have basically the physical characteristics of an adult. So when do we call puberty being early, which we also call it precocious? So for girls, that's going to be age 8. For boys, that's going to be age 9. And I'm going to give you guys more context on how we came up with those numbers. So there have been multiple population studies that basically looked at what's the average age of puberty initiation in the United States. So basically you look at, you know, a huge population, you follow them through time, you see when they started puberty, you get an average, and then you can see basically, you can like distribute that population on percentiles. You can see, you know, kind of like third percentile, 97 percentile, and then your average. So we actually identified that there's going to be a small subset of kids that are going to obviously start puberty maybe a little bit early, obviously, than the average, but still be within what is considered, I guess, a normal distribution. And that's where those numbers came from. So there's going to be a small subset of girls that can start puberty as early as age 8 and still be normal, considered normal. And then a small, excuse me, a small subset of boys that are going to start puberty as early as age 9 and still be considered normal. So in clinical practice, most of our patients are basically patients that, the patients that get referred to us for early puberty are going to be girls that are starting puberty before age 8 and boys that are starting puberty before age 9. And by that, we mean, you know, we're going to talk a little bit about some normal variants and some differences, but we're talking about the girl that's starting breast development or breast budding before age 8, or the boy that is starting testicular, I guess, activation, testicular enlargement to a certain size before age 9. So I mentioned before that we have some benign variants, and I think that this is important to briefly discuss. The names of them don't necessarily really matter, but this is more of like a comment on the fact that not every single patient with a sign of physical maturity that seems early necessarily will have what we call true puberty, which again is activation, or it's, I guess, triggered by estrogen in girls, testosterone in boys. There are some normal variants where we can see some physical development, but it may be related with benign physiologic processes, maybe happening a little bit early, but that may not necessarily have significant clinical relevance. But nonetheless, it's important for the parents, obviously, to be aware of this. And we actually encourage patients to obviously have their kids assessed for any concern for early puberty, even if at the end it may not necessarily be true precocious puberty or true early puberty, but it is important to have a provider take a look at this and make sure that we are not dealing with something that would need more medical attention. And just briefly, I have 4 terms here. The first one is premature thelarchy, which means basically early breast budding. This one applies mostly for girls. Sometimes we can see babies that are as young as less than age 2 that are having some protuberance or some breast budding. We do recognize that there is going to be some physiologic, sort of like expected physiologic elevation in some of the pituitary during the first 2 years of life that may actually leave some breast budding, but this typically doesn't last beyond age 2. So we typically just monitor for that. And if it actually goes beyond age 2, we may need to then at that point consider something else or more evaluation of that. There is pubic hair of infancy. So sometimes we have some babies that have some pubic hair. This pubic hair is usually very fine, usually minimal, usually of no concern. And again, it's sort of like a expected transient physiologic process that typically, again, does not represent true puberty. We have premature adrenarche, which is physiologic activation of the adrenal glands, which are these glands that we have on top of our kidney. They actually make some hormones that are important for physical development as well, like the development of some of the secondary sexual characteristics. But sometimes they can get activated a little bit earlier. They may secrete or produce slightly higher levels of androgens, which in turn then give some pubic hair, can produce some pubic hair, axillary hair, body odor. But after an evaluation, once we have actually ruled out some other causes, if this seems to be the diagnosis, typically it's benign. It's something that progresses very slowly and typically doesn't lead to true early puberty. But again, it does require a provider obviously taking a look at a few things. And then we have some cases that are rare but can happen of non-progressive or intermittently progressive precocious puberty, where like the patient may have signs of true puberty, but it seems like actually they don't necessarily progress as fast as you would actually expect for a patient who's in full-blown puberty, which can happen sometimes because hormones are tricky, and especially sometimes we do need what we call pulses of hormones, which is when our body is kind of like secreting a lot, then doesn't secrete a lot, then secretes a lot and whatnot. So sometimes if that is happening sort of like intermittently, that can actually lead to intermittent sort of like effects of those hormones, but it's not necessarily progressing as fast. So as I mentioned, there are some times where we may actually determine that the cause of those physical changes may not be actual true puberty. What are the causes of early puberty? So let's say, what are the causes or the potential causes of a girl starting breastfeeding before age 8, or a boy starting to have testicular enlargement before age 9. We do recognize that most of the cases actually are idiopathic. However, I do have to say, idiopathic in our jargon means basically no identifiable cause, but I do have to say that most of these cases are actually genetics. It's just that there are so many genetic mutations that can be associated with it that we unfortunately are not able to obviously identify all of those, but we do recognize that most cases are just genetic variations that just basically prime our bodies to start puberty early. We do have familial and genetic cases that are well identified. We do recognize that patients with underlying neurologic conditions from any sort of like a spectrum of neurologic conditions like epilepsy, autism, kids with developmental delays can actually have a higher risk of precocious puberty or early puberty. Tumors in the pituitary can cause early puberty as well. Genetic syndromes, as I mentioned, secondary to medications when there is exogenous exposure to either estrogen or testosterone, accidentally or non-accidentally. We do recognize that patients with high BMI, high body mass index, whether it's in the obesity or overweight range, they can actually enter puberty early. And then some cases of really profound hypoactive thyroid gland hypothyroidism can also present with early puberty. For the diagnosis, as I mentioned, the most important thing is that if there is a concern about that, obviously consult with your provider. Most likely, if you consult with your primary provider, they're going to recommend an evaluation by an endocrinologist. We're obviously going to get a good history. We're going to get a good exam. And then based on what we suspect, we may most likely get some blood work and an x-ray of the left hand, which is called the bone age. Usually those first two tests allow us to get a good grasp of whether we're dealing with true puberty and kind of like what's the extent of things. And then we may want to get a pelvic ultrasound in some cases. And then if we actually diagnose that the puberty is being activated or starting from the pituitary gland, from the central activation, we may get a brain MRI to look at the pituitary gland and make sure that it looks normal. But at the very minimum, usually we will get blood work and an x-ray of the hand. In some cases where we may not be completely sure about the diagnosis with the initial workup, we may get some more testing, stimulation tests, dynamic tests, things that we are looking to try to get more accurate results from those hormones, because as I said, measuring hormones may be tricky. So sometimes we may not be able to do it just in one single test. What are the consequences of early puberty? The two major consequences are going to be consequences for growth and consequences for psychosocial distress. As I mentioned before, normal puberty is very important for growth. As I mentioned, there's going to be a significant increase in growth hormone production. So there's going to be a growth spurt during puberty that, it's very important for the final adult height. So basically with growth, what I'm talking about is that puberty, if it happens too early, it can actually also accelerate the growth of the kid early on, but at the same time, it may lead to premature closure of the growth plate. So they may actually end up shorter. Shorter may be shorter as in like, kind of like normal, I guess, out of the normal, distribution, or it can be shorter based on their genetic targets. So any of those. And psychosocial distress, obviously, we do recognize that obviously for some patients, for majority of patients, I would say it's going to be obviously distressing going through these physical changes at an early age when their friends or their peers are not really going through it, which can also lead to instances of bullying or instances of like isolation, things like that. Also, especially for example in patients with developmental delays, the potential progression through puberty may actually lead to some challenges in the care as well once menstrual cycles start in girls. So those are part of also like the potential psychosocial distress or care challenges in those kids. So just to exemplify more or less what I'm talking about growth, this is a case where, like, let's say we have a girl with normal puberty. She had a target height of 5 feet 4 inches, and then her actual height going through puberty at a normal age was 5 and 3.5. So she grew to her genetic target. But let's see what happened to her if she were to start early puberty. Again, she had a target height of 5'4", but her actual final height was 5 feet because of the early puberty. What is the treatment for early puberty? I'm not going to obviously necessarily go into details of the treatments, but just a general overview of what we would do. If there is an underlying problem, then we would treat that, of course. As I mentioned, sometimes most cases actually are without an identifiable cause, which again, most likely are genetic cases. But there are cases where you may need to treat another problem, another health problem that is causing the early puberty. As endocrinologists, basically what we do is that if we do diagnose early puberty and it's being triggered by the pituitary gland, it's central puberty, then we will use some medications. We have some injections, implants, things that we can use to block puberty. And then in other cases that are more rare, where maybe puberty is actually coming directly from the periphery, like the testicles, we may need to use other medications. And again, with the goal of basically trying to preserve final height, trying to avoid psychosocial distress if we can, to promote as much of a normal growth and development as we can in our kids. And again, just pretty much the message here is early puberty can be a significant issue for growth and development in some patients. Not all the time, but it's going to be important to recognize basically when that is happening. And the message is obviously talk to your doctor, make sure that your kid gets obviously a good examination, and if there is any concern, the endocrinologists are always happy to help to figure out if there is something else that needs to be done, and then to try to obviously keep our kids in the track to reach an adult height that is healthy, that it's within their potential. And I think with that, I will conclude my talk, and I will give it back to Dr. Stillman.
Oh, thank you very much, Dr. Otero. We'll hold off on questions until we get to our panel. But if you have questions for Dr. Otero on puberty or other things related to puberty, please go ahead and put them in the Q&A or the chat. And we'll try to get those, as well as just handle questions from others who've spoken before. So before we go to the panel, though, I have one final set of speakers here. So I have Caden and his mom, Valerie, here. Hello, how are you?
We're good. How are you?
When did you find out that Caden had OI? Was it something that you found that was possibly hinted at during the pregnancy, or was it something that ultimately was discovered after he was born?
So during the pregnancy, I opted out of the amniocentesis, which probably would have told me, about the OI. But everyone guessed it was dwarfism, just a type of dwarfism. By the time he was born, we actually did a skin genetic test, and that told us, took about 3 or 4 weeks to tell us that what he had, OI type 3.
Okay. And then tell us a little bit about the nursery course. I mean, I think, I've had a number of cases that I've handled, so I sort of know this story, but every story is a little bit different. But oftentimes it begins with prenatal ultrasounds and a question on, the baby doesn't seem to be growing, or the bones don't quite look right. But the nursery course from child to child can be a little bit, some skate on through, some it's a little bit more stormy. I guess tell us a little bit about the how he did and how the nursery staff helped you as far as taking care of him early on.
Well, so when we did the anatomy scan, that's when they started noticing that the long bones were not growing at a normal rate. And so they referred me to a specialist over at Medical City. They did more, tests. We did an ultrasound every couple of weeks. We did blood tests. And I mean, they just saw that he wasn't growing normally, especially, his skull. There wasn't any calcifications, like his lungs were very small, his heart was very small. And, they guesstimated that he probably wouldn't make it, outside of utero.
What do you mean? I'm a good boy.
I know.
So,
And there you
yes.
are.
Big blessing, big blessing. But every doctor, every nurse that I saw, they were very supportive. And there were a few, that were very negative in the light of, he wouldn't be able to walk, he wouldn't be able to do this and that. And, but, just having the other positive people in our life, reassure us that everything's going to be
Well,
okay.
I proved them wrong.
You did prove
Yes,
them
you
wrong.
did.
Yeah.
Well, I guess tell us a little bit about, early on for him, once you brought him home and just some of the things that you found, for other families that, again, I'm sure you've had a chance to talk to families who, were earlier in the journey than you are. So what did you find was, perhaps the biggest challenges early on once you brought him home from the nursery?
The biggest challenges were just resources about, what to do when he has a fracture, how to manage pain, how to diagnose when he's in pain and not just a normal, infant crying. And then other challenges being, starting school, just kind of putting him out there in the general population, as a normal kid, because he is. There was a lot of pushback with that. So, I guess it was more challenging just with resources. There's not a lot out there because it's so rare, but I think now there's more awareness. We tried our best to spread awareness any chance we can.
That's good. Where did you find the most pushback initially?
It was starting school, initially pre-K.
Was that through sorry not to interrupt you, but was that from the staff themselves feeling anxious, or where did you see that pushback?
It was definitely with the staff, the people that were going to be handling him, the teacher. There was a nurse's aide, and then the nurse at the school, because we were going public, which was fine. I totally understood. And I told them, I don't want to push you into anything you don't want to do. But, my son is normal and he's going to go to school like normal. So we will do everything we can to make that happen. And they did. They got on board. It took them a while, but there was pushback as to like, well, how do we do this? What do we do when he breaks or when he has to go to the bathroom? Because, he needed a lot of help with that, being a kid in a wheelchair. So, but he's been going to that school for what, 6 years now, 5 years now. So, they're pretty used to him.
Tell us, I guess, let me shift the questions to you, Mr. Caden. So yes, I can see you're very strong. So how's school going this year? And I guess tell me a little bit about, you going to school, how your day is like, and, how especially there's some kids that maybe haven't seen you before, that maybe come in your grades. How do you, when you talk to them or they have questions for you, what do you tell them as far as, what's going on with you?
I just tell them all the OI stuff, and then they're like, okay. And school's been great.
That's good.
Yeah, they's really good. I got
What do
all
you,
hundreds.
that's good. I'm glad to hear that. What do you like best about school so far? What's your favorite subject?
Math and reading.
Oh, very nice.
Maybe
Okay.
everything.
Do you have any challenges right now as far as being in your wheelchair? Because I know you use your wheelchair most of the time for getting around some. At school, do you feel comfortable with maybe not using your wheelchair, or pretty much out in
Yeah,
public?
yeah, I'm comfortable with that.
He actually asked me the other day if he
Yeah,
could
everyone
get out of
does.
his wheelchair during class because, sorry, there's a part of the day where they get to sit on the floor
Yeah.
and do some reading and stuff. And he asked me if that was okay. I gave him the go ahead because he's, at this age, he's very, protective of his body anyway, and he'll let you know if you're too close.
Yeah.
But yeah, we still have, his wheelchair at school and then his walker in case, he wants to roam the classroom as well.
One thing too, and you can tell me from your perspective, but I've been doing endocrine and have done bone stuff and work with children and families with OI, gosh, since the early 2000s. And I've been really amazed at just how the team approach has really gotten much stronger, and also things like putting metal rods in the bones has really helped as far as mobility and just giving kids and families options besides just being wheelchair users. I mean, again, for long trips and things like that, wheelchair is pretty much the way to go. But it's amazing though how much transfers and other things I think have just become a lot easier and better. I mean, would you say that's kind of your perspective, or what do you see?
Absolutely. Ever since Caden's had his rods put in his leg, but both extremities, 2013, I think it was. I mean, we still have fractures every now and then, but as far as weight bearing and being able to, do things like walk, have been, I mean, absolutely incredible. He did have a setback, he's very active, so he loves to, get up and crawl and walk. And then, just a cycle of fractures happened. And so he had to be, put back in the wheelchair, and then we had surgery. But definitely having those rods there is just like another form of protection.
hmm I agree. They've really become, I think, the mainstay, and they've gotten a lot better in terms of that. I guess, Caden, tell us a little bit too about growth on you. So your particular condition definitely does have short stature. So some kids or even adults may look at you and think, oh, you're much younger than your actual age. So how do you handle that?
Oh, I say you're.
We have a problem at well, it's a minor issue at school where some kids call him small or ask him, what size clothes he wears because he is smaller.
Yeah.
And he comes home and it does bother him. But we try to, just give him like positive feedback for those people, just educate them on OI, and everyone, is a different size, shape, and color. So, there's no two people the same. So we have dealt with a little bit of bullying from a couple of kids,
Okay.
mentioning how small he is.
Yeah, I can imagine that can be something that can sometimes just frustrate you extremely. Especially, I know when I talk to the kids, with OI or with other, forms or conditions that, tend to make them really short. It's frustrating. It's like I'm not, a little kid. I'm a almost
Yes.
10-year-old, or I'm a teenager, or things like that. So I can understand that. So we'll see maybe what if Thomas has anything to add on bullying here. What about just other things from standpoint of health on him? Just educating people that maybe don't know about OI. I think. Well, go ahead and tell me what you think, and I'll just have one other thing I was going to add.
I mean, so typically if they don't know, if they, see Caden in his wheelchair, A lot of people don't ask questions, but if they do, I'll just start from the beginning, that OI is a genetic disorder, his bones are brittle, so we have to be very careful with him. Mainly, just letting him guide us in what he needs and what he wants to do. That can be scary for a lot of people, which is understandable. But once they see him, running around and, being a typical 9-year-old boy, it doesn't get so scary for them. So we try to educate as much as possible, especially when we're out in public and there's a lot of eyes on us.
I think I agree with you on that. I think that certainly with OI, and I think with other conditions as well. Again, I think that if people take the time and really listen or look a little bit more deeply, they really can realize that there's very little. It's kind of like when you were talking with the preschool staff. I mean, there's a lot of scariness initially, but just taking the time to understand and taking the time to go forward with it, it becomes a little bit less scary. I think that's true for a lot of conditions. I know certainly for families that are, have new diagnosis for type 1 diabetes, childhood onset insulin dependent diabetes, that can be really challenging for them to have to start explaining, what they need to do in order to, to maintain their health and just the things they have to do to take care of themselves. A number of them wear, diabetes technology and gear on them that's very visible, and people, ask questions. Well, what's that, thing that you're wearing there? So I don't know what, from your standpoint, Caden, what do you feel like is maybe the most challenging thing for you on a day-to-day basis, as far as, just every day? Do you find that it's hard sometimes to reach and grab things, or is it getting your wheelchair around, or?
So any challenges from your day-to-day basis?
No.
He kind of just makes everything work. He just figures it out.
Sounds good.
But I mean, there are, because he is shorter, so there are some challenges and, reaching. Most recently, toileting has always been an issue, not an issue, but, something he's always needed help with. But recently he's become independent in that area. So, that's just another level of confidence. But for the most part, I mean, he figures it out.
Yeah.
Yeah,
I think that's great. I mean, I think, as you look at, and I don't know if you, look at some of the other people out, adults out there in, in the world with OI, and ever kind of look at what they're doing and things like that. I mean, some of them don't have the, advantages or that you had. So things like the surgeries and things like that that you've had, they didn't have the benefit of, or, the use of bisphosphonate infusions as well. But, there's a lot of them out there. The one, I guess, when I think about here in the United States, I think about Galen Lee, who's the violinist, and how, she, the performer, and, really just, tours and, has found a way to play beautiful music and be a really, an impacting performer. Did you go mute on me here?
We did. Sorry, our
big.
baby is crying upstairs, so we're trying to
Oh no!
get dad to.
I'm sorry.
No, you're.
Well, we're just about to go into I think panel anyway. We'll have people that will have some questions for you all. But is there anything else that you guys wanted to add while you're still the solo act here?
Is there anything else you wanted to add?
Yes.
Okay, go ahead.
So one time I figured out how to reach the lights because I'm short, is because get a long thing and then reach it up and then turn the switch on.
Mm-hmm.
Yep.
I guess
I was I'm sorry, go ahead.
I was just gonna say, I guess my question would be, for Caden and his diagnosis, do you predict any time in the future that there would be a chance for growth hormone treatment?
Potentially, I suppose. I mean, growth hormone treatment has been something that's been studied. It's been a long time ago in osteogenesis imperfecta. Of the, the forms that where there's been at least some notable possible improvement, has been in the type 1 form of osteogenesis imperfecta, which is the mildest. But that being said, you brought up a topic that we can talk about when I see you guys face to face here, just to see if there's anything new. I'm not aware, or excuse me, type 3 right now that there is, but that being said, we could possibly look at it again. Is
Okay.
with anything, you want to look at what's the balance of the benefits versus what are the risks or downsides. So we'd have to have a pretty detailed consideration on that.
Right. I understand. Okay.
Well, I guess I'll bring everyone else back on. Let's see. I've got to make sure I've got my schedule up, but I think we're ready to bring the full team back on here. Let me see if we had any questions here.
Looks like
Oh,
Caden.
this is I beg your pardon?
Looks like Caden has been the star of the show.
Yes.
Yes, of course.
So I guess a question, I'll start with you, Kathy. So, and if I can, I'll certainly answer, and Dr. Otero as well. This is a question about growth hormone treatment, and we were talking about insurance. So do you know yet if weekly growth hormone is going to get covered by insurance?
I think that at the moment, my understanding is they're still working on that process.
Mm-hmm.
I think since, things just were approved, the medication was just approved, I think that they are, diligently working on, procuring contracts and such. But I think at the moment, it probably is not yet ready for approval by, insurances or PBMs. Or so is my understanding.
Mm-hmm. And PBM is
We're
pharmacy
waiting
benefits.
anxiously. Yeah, we're waiting
Right.
anxiously for sure.
I agree. And I think, Dr. Otero, do you have anything you want to add on that?
No, exactly the same. I have a colleague who I think recently tried and got denied, but basically what they're saying is that, hopefully soon, I guess if we start trying it and running it, and hopefully they will soon approve it. But as of now, I think that yes, it's not yet approved by insurance. Yeah.
And I agree. I think, as we've looked at other new therapies as they come on the market, one of the challenges, it's like, we get all this information that's presented to us, and we may, in the olden days with the pandemic, that's certainly been limited, but we would have, medical experts within the company come and tell us all about, their new product and all these things. And that's, and again, that's always exciting, but there's always the logistics of once that, while we have it and we know about it, having the insurance companies and the pharmacy benefits managers, which are, the medical pharmacy specialty pharmacies that will handle the actual dispensing. Because I think the other thing people may not realize is that, you can't just write a prescription and run down to your local Walgreens or CVS and pick up a growth hormone prescription. It's handled through a specialty pharmacy and shipped, and there's training and things like that. So anyway, we'll see though. I think that'll be an important question. And I think over time it'll be taken care of. There's a question too about for Caden and his mom. So what is OI, and also you're 9, how tall are you?
3 foot, 3.5.
Okay.
Yeah.
Well, how would you describe what is OI, which is for osteogenesis imperfecta?
Yeah.
How do you describe osteogenesis imperfecta? Like, what is it? If you were to tell somebody new about it, what would you say?
Um, uh,
It's a bone disorder. We'll put on the spot here.
Uh-oh.
I don't know. I don't know what I would describe it.
So OI is a bone disorder. It affects the collagen gene.
Yeah, it affects like your bones.
It does affect your bones. It makes them very fragile, right?
Yeah.
Uh-huh. You have to be extra careful.
Beep.
Sorry, brother just woke up.
I can tell. It's like brother's definitely got lots of energy there.
Yeah.
Okay. Let's see what else we've got here for questions. I have to go all the way back to the beginning here. Let's see. Before this is a more involved one about growth, but before I do that, can I ask Tom a little bit? So I was interested when you were talking about bullying. So what's been your experience? We've seen here at in North Texas a real upsurge in depression and a real upsurge in, unfortunately, suicide attempts or actual completed suicide. So what do you find right now are strategies that can help families and children really cope with the stressors going on here? And also, just as an add-on, I've been aware of much more cyberbullying too. Now that, there's not the in-person, there seems to be movement towards more cyberbullying.
Right. There has been an upsurge in depression, but especially anxiety. That's been pretty pervasive. And so there are some steps that the person, child, adolescent, and family can take. The first step is sort of being more aware of mental illness. And
Mhm.
it's a real thing, and we can talk about it successfully. Suicide, we can talk about that, having suicidal thoughts. It can be quite normal in certain situations, but acting upon it is not normal. And so that requires maybe even a hospitalization or a deeper intervention with a therapist or a psychiatrist, and maybe even some medication.
Mhm.
Being able to talk and have support and to not hide behind, oh, if I'm depressed, I'm going to be viewed as less than, and I don't want to, or if I have anxiety or an anxiety disorder, then I'm going to be picked on and viewed as less than. So I think talking about it is such an important thing. Cyberbullying, um, if you can turn the electronics off and get a break from them, that's huge. I have parents that I even encourage and suggest that there's a time limit for when they can use their devices, and then they turn them in to their parents over the course of the night. So let's say they get all their homework done, and then as a reward for finishing their homework, they get their phone for 2 hours, and then they have to turn it in, a half hour to an hour before bedtime. And then the parent keeps the phone, and they don't have access to that. Same thing with computers and tablets and things like that. Taking a break from it is so important instead of being bombarded by it. I think that's one way. Also on social media, or when there's cyberbullying, if we can address and encourage, especially younger people, to address when they see something, to call them out on it, and tell that person, whether it's a fake person or not. Sometimes kids create accounts, fake accounts, and impersonate other kids and are mean
Mhm.
online. Just to call them out in open, that this is not appropriate. We're not going to tolerate that, and to delete those things and to not focus on them. I think Caden was a tremendous asset to have today, and I admire your courage and your strength and your just your temperament alone is like, I'm better than this. I'm not going to allow this to get me down. So I think that you're not going to have any problems in the future. Yes, it hurts it feels bad when people pick on us and bully us, but if you continue and mom continue to promote his um, uh, the fact that he's good and he's a great human being and that he is
Mhm.
strong and that he overcoming it, being able to overcome adversity is such a tremendous strength that people admire, that I admire. So thanks for being here, Caden, and I hope that helped answer the question, Dr. Steelman.
It does. I one other question just on follow up, because again, I think you've talked about just fostering a sense of worth and self-esteem. So if you're presented with a challenge, physically or with some condition, be it osteogenesis imperfecta, growth hormone deficiency. Certainly sometimes there can be pretty extreme short stature initially, or diabetes, where you're in doing chronic medical management. Are there any, I guess, things that you find that really help families and help children, when they're feeling low, to really sort of look at things with in proper perspective?
Yes, sir. Focus on the things that you do have, adopt a mindset of gratefulness, and focus on your own strengths. So if we focus on our weaknesses or even our challenges, that could drive us down into the doldrums. But if we focus on our strengths and we
Mm.
focus on developing those even stronger and finding people that where we do have a challenge, they might have a strength and we can rely upon them, and vice versa. Because I'm sure that when it comes to Caden and Valerie, he needs mom to help with certain things, but I'm sure he helps his mom with many things. I'm sure it has made her a better woman because of having him.
Thank you. That's very inspiring. Um, there's a question that is from a parent asking, I guess, more about a related to their family. So the gist of the question is about a scenario where mom is taller than average, dad is average heighted. So, based on mid-genetic height target, this is a boy. This boy should be above average, above the 50th percentile, and yet the growth has been consistently at the 15th percentile. And looks like there was some initial um, problems with feeding early on. But the question really is there a concern? Um, and I'll let Dr. Otero also, who's a peds endo, weigh in and see if he has any other things to add. But I mean, certainly that's a pretty big difference between where theoretically we might see this young man and where he is right now. Again, not having a lot of details obviously makes it hard to be concrete, but I think I would definitely say that with that degree of difference, that there should probably be some type of, if you're concerned, obviously, and I appreciate you again taking time to be part of the HGF Family Day today, and also hopefully for support and you know visiting our website and enjoying and finding benefit out of what we do. But anyway, I would encourage you to um, go ahead and have a more in-depth discussion with your primary care person and talk to them about maybe a referral to endocrinology. Dr. Otero, do you have anything else you would add?
No, I agree with that. As you mentioned, there are some cases where there is discrepancy or a significant gap between the genetic target height and where the kid is currently growing. So I do agree with you. I would just encourage the parents to talk to their primary care provider, perhaps getting evaluated by
Mhm.
endocrinology and going from there.
What about, so again, thank you again for taking time out of your busy schedule today to speak to us on precocious puberty. Are there any red flags that you would suggest parents look at as far as, seeking evaluations for their child?
Yes, absolutely. From a puberty standpoint, trying to remember those two ages, age 8, age 9. So age 8 for girls, age 9 for boys. So any sort of like physical development that may be concerning, early appearance of pubic hair, axillary hair, body odor, enlargement of the genitalia, breast budding in girls. Again, it may just be part of a spectrum of normal variants, but it's important to actually get that extra evaluation, touch base with their primary care, having someone examine the kid, because if there is a problem, it may have significant repercussions for the kid in the future, especially in growth, development, and mental health. So I think that definitely recognizing those patterns, and then from a growth standpoint as well, a kid who's having a slow growth velocity, or the opposite, a very fast growth velocity, those things should also be red flags to act upon. Again, not necessarily every single case means abnormality, but I think that being red flags basically means that you do need some extra evaluation to make sure whether it's something that needs to be addressed in depth, or maybe something that just needs to keep an eye on.
Okay, thank you. Is there any other things that people on our panel want to add at this point? I think we've covered all the questions. So Caden, anything else you want to say before you sign off? You're a good big brother, it looks like.
We appreciate you having us.
Well, thank you all again. I appreciate you taking some time out of your Saturday, and also there's a number of people I don't think that have heard of OI. So thank you very much for helping with that. And thank you, Dr. Otero. Thank you, Kathy. Thank you, Thomas. I really appreciate you all, and the audience as well too. Before I finish up, just a couple of housekeeping things. Again, thank you again for our sponsors on the logo there, and for your virtual exhibit hall. And at the end, there's also the chance to do a survey. So this is very helpful as we want to hear from you, what you find valuable. And then I guess the last thing I'll just say is that I hope that next year, I've had the pleasure of doing in-person family days in the past, and so we've had this year and last year virtual, just because of the pandemic. So I very much hope and pray that we will be back and in person. And if I could be so bold as to say this as a physician as well, but I would really encourage people to continue to, I know it's very fatiguing, but to continue with all the things such as social distancing, masking, vaccines for children 12 and up, and for the adults as well. I think many of us in the medical field have unfortunately seen way too much tragedy that's happened in families. And so that's my final word. But again, thank you all very much. And thank you all for your support for the Human Growth Foundation. We'll see you again next year for Family Day.
Thank you.
Thank you.
Thank you.
Thank you all.
Bye.
Thank you.
Thank you.
Bye.
Bye, Caden.
Bye.
Bye.
Bye.